everyone. Now we'll see the causes of vertigo and dizziness. First most important thing is benign paroxysmal positional vertigo that can be easily asked in the question. The examiner will tell you that the patient has got vertigo which is usually persistent for seconds and is aggravated with head position. This is the clue to diagnose benign positional paroxysmal vertigo. Remember, it is the Dix-Hallpike maneuver that is diagnostic and the treatment is Epley's maneuver. Epley maneuver is the treatment for benign paroxysmal positional vertigo. Next, we talk about Meniere's disease. In Meniere's disease, I want you to remember this one is for lifetime, VATS. Even this is important for PLAB 2. Meniere's disease, it is vertigo, oral fullness, tinnitus, and sensory neuronal hearing loss. This is Meniere's disease. What do you have to do? Whenever there are four criteria, whenever there are four symptoms, that is vertigo, oral fullness, tinnitus, and sensory neuronal hearing loss, it is Meniere's disease until otherwise proven. Remember, in Meniere's disease, the examiner can frame a question like this. The examiner mentions that an episode of dizziness or an episode or recurrent episodes of dizziness usually associated with vertigo, tinnitus, hearing loss with oral fullness, it is Meniere's disease. What is the treatment for Meniere's disease? It is bed rest and reassurance. Sometimes most of the patients do use a medication called as beta histine that can be the treatment for Meniere's disease. Next, we talk about vestibular neuritis. Please do remember, for a patient to develop vestibular neuritis, in the question the examiner will tell you or talk about viral infection. Vestibular neuritis can also be a complication of post-viral infection. This is one thing you will have to remember. Whenever there is vestibular neuronitis or vestibular neuritis, there will be sudden onset of vertigo associated with nausea. All right. If there is post-viral infection or inflammation associated with vertigo, nausea, vomiting with hearing loss, it is labyrinthitis, please. Remember, this can be asked in the question because this is a new concept, vestibular neuritis and labyrinthitis. If it is associated with hearing loss, it is labyrinthitis. If it is not associated with hearing loss, it is vestibular neuritis. I want you to understand that the treatment is reassurance. Sometimes sedation can be usually used for treatment of vestibular neuritis and labyrinthitis. Next, we talk about posterior circulation stroke. Whenever I see posterior circulation stroke, it is usually affecting cerebellum, that is causing vertigo. Vertigo, dizzy plus dysarthric patient usually has got posterior circulation stroke. Remember, whenever you are in the front door working in A&E and now the patient walks in complaining of constant dizziness with associated risk factors such as smoking, hypertension, diabetes, hyperlipidemia, CT scan is negative. What do you think of? It is the posterior circulation stroke you'll have to think of. It is the cerebellar infarct that you will have to think of. On examination, there will be past pointing on cerebellar infarct. This is one thing you will have to remember for posterior circulation stroke. I also want you to understand that CT scan can be negative in posterior circulation stroke because MRI is a good imaging technique in order to view your posterior part of the brain. Apart from this BPPV, that is benign paroxysmal positional vertigo, Meniere's disease, vestibular neuronitis or vestibular neuritis and posterior circulation stroke, there are other conditions that can cause that can cause vertigo and dizziness. It is the migraine. It is the basilar migraine that can cause vertigo and dizziness. It is also an important cause for vertigo and dizziness, please. Next, we talk about tinnitus and hearing loss. One most important thing we discussed in tinnitus and hearing loss is Meniere's disease, please. Meniere's disease is one most important cause of tinnitus and hearing loss. That's most important thing. Please do remember that there can be ototoxic drugs that can be given in the question which can cause tinnitus and hearing loss. If it is pulsatile tinnitus, I want you to think of vascular causes. If it is pulsatile tinnitus, if the patient has got pulsatile tinnitus, it is basically vascular causes such as jugular tumor, commonly called as glomus jugulare. Patient can also be having carotid dissection or carotid stenosis or AV fistula. These are the things where there can be pulsatile tinnitus. Next, we talk about the management of pulsatile tinnitus. Usually, it is the tinnitus retraining training. That is one thing you will have to remember, please. So, this was recently asked question. Tinnitus retraining training. Most of the people with tinnitus usually live with tinnitus, so we will have to make sure that CBT can be helpful or tinnitus retraining training can also be helpful, please. All right. Next, we talk about functional neurological disorder. I want you to understand, whenever you are thinking of functional neurological disorder, all the investigations are normal. First most important thing, all the investigations are normal. Say for example, if the patient has got a seizure like activity, but in seizures you will find tonic clonic contraction of the upper limbs and lower limbs. But in functional neurological disorder patient who has got seizures, it is basically flaccid things. So that is one thing where EEG is normal, MRI is normal, imaging is normal, electrolytes are normal, infection screen is normal, everything is normal. This is functional neurological disorder, please. All right. That's one thing I want you to remember. All right. Next, we talk about acute bilateral leg weakness. Before talking about acute bilateral leg weakness, I also want to talk about the hearing loss. For hearing loss, if the patient is young patient and has got a hearing loss, I will be doing an MR scan of the brain. On the MRI scan of the brain, if the patient has got bilateral acoustic neuroma, it is neurofibromatosis 2. That is one thing this needs to be remembered, please. All right. Whenever there is acoustic neuroma, it is bilateral acoustic neuroma is usually associated with neurofibromatosis 2. Next, we talk about functional neurological disorder, and next we talk about acute bilateral leg weakness. Two most important causes for acute bilateral leg weakness. This is acute bilateral leg weakness. What did we discuss in our previous lectures? Whenever there is spinal cord that is involved, if a spinal cord is involved, what do you have to think of? You will have to think of bowels, bladder, and sexual dysfunction. If patient has got bilateral leg weakness with bowel and bladder, it is spinal cord until otherwise proven. All right. That's one thing you will have to remember. Whenever there is a cord compression, patient usually presents with weakness, bilateral weakness with bowel and bladder dysfunction. It is cord compression until otherwise proven. What are the most important causes of cord compression? Patients usually have got malignancy that can cause cord compression. This is one thing you will have to remember, please. No matter what, you will have to remember this. All right. Next one is infection. What infection can cause cord compression? It is the epidural abscess. Remember, for UK exams, if there is a abscess in place, it is basically, the question is basically mentioning about fever. Fever with bilateral weakness with bowel and bladder sign, it is cord compression secondary to infection. If there is no fever but it is associated with weakness, bowel and bladder dysfunction, it is cord compression secondary to malignancy. Next most important thing the examiner can ask you is, what is the investigation you do for cord compression? It is the MRI whole spine. All right. That's one thing you will have to do. What is the next best treatment for cord compression? It is the dexamethasone. If you do not find dexamethasone, it is the steroids that gives you the marks in PLAB 1. All right. The examiner can ask you, the patient is started on steroids. What do you need to monitor? It is the blood glucose or blood sugars that you will need to monitor, please. All right. Next, we talk about cauda equina. Whenever there is saddle anesthesia with bowel involvement, again it is cauda equina. You'll have to do an MRI scan that you will have to consider, please. The most important differential thing is cauda equina versus conus medullaris. Remember, cauda equina and conus medullaris, it is the upper motor neuron lesion and lower motor neuron lesion. Cauda equina is lower motor neuron lesion and conus medullaris is upper motor neuron lesion. Alright. Please do remember that conus medullaris can sometimes also be presenting with upper motor neuron signs and lower motor neuron signs as well. There can be leg weakness, there can be urinary retention, but there can be back pain as well. Whereas cauda equina can cause back pain, but there will be radicular pain. What do you mean by radicular pain? I'll tell you. Cauda equina versus conus medullaris. Conus medullaris is basically upper motor neuron plus lower motor neuron signs, whereas cauda equina, it is lower motor neuron sign. Remember, this is the spinal cord, this is conus medullaris, this is cauda equina. So there will be pain along the nerve root, so there will be lanciating pain that is happening from the back to the limb or something like that. Alright, whereas conus medullaris, there will be back pain that is affecting the conus medullaris. This is a part of the upper motor neuron. So upper motor neuron signs are usually seen in conus medullaris. Whereas cauda equina, this is a nerve root that is affected. So it is usually the element sign that is commonly seen. Alright. Patient can also present with asymmetric leg weakness. That's one thing you will have to remember, please, because one side of cauda equina is involved, whereas if conus is involved, it is the bilateral leg weakness with back pain, with upper motor neuron sign. You will have to think of conus medullaris. Please do remember, if the patient has got cauda equina, there will be areflexia, that is no reflexes are seen in cauda equina syndrome, whereas conus medullaris, there will be hyperreflexia that can be seen. Alright, next we talk about the sphincter loss. Whenever there is decreased sphincter tone, it is cauda equina until otherwise proved. What is the next best investigation? It is the MRI. And what is the treatment? Treatment depends on the MRI findings, please. Alright, next we talk about gait disorder. I want you to understand that if the patient has got a spastic gait, it is upper motor neuron lesion. In this upper motor neuron lesion and in hereditary and in spastic gait, one thing is hereditary spastic paraparesis, where hereditary spastic paraparesis is nothing but lower limbs become stiff, increased tone with spasticity. There will be presence of clonus with weakness secondary to upper motor neuron lesion. This is one thing I want you to remember, please. Next we talk about ataxic gait, that can be because of the cerebellar gait or alcohol gait. Remember, whenever there is an alcohol question asked in PLAB 1, it usually causes cerebellar degeneration that can cause ataxia. But how do you differentiate ataxic cerebellar ataxia from alcohol-induced cerebellar ataxia? Please to remember that alcohol-induced cerebellar ataxia is caused by excessive drinking. So it causes nutritional deficiency. It causes macrocytic anemia. So please look at MCV. When you look at MCV and when MCV is more than 100, you will have to think of alcohol-induced cerebellar degeneration, and then it can cause ataxia as well. Alright. Most of the patients will be having apraxia as well. What is apraxia of the gait? Apraxia of the gait is nothing but difficulty initiating the gait. When do you find this difficulty initiating the gait? In what condition? It is normal pressure hydrocephalus. It is usually dementia, ataxia, and urinary incontinence that is seen in normal pressure hydrocephalus, please. Apraxia of the gait is usually seen. All right. Next, we talk about Parkinsonian gait, where there is short shuffling gait with stooping posture. That is one most important thing. Patient will be having difficulty while taking the turns. Next, we talk about myopathic gait, where examiner can classically mention that it is a waddling type of gait because of the proximal muscle weakness that we usually have. This is about gait disorders, please. I want you to remember the conditions that can cause this gait disorder and how to identify those conditions or the etiology that we will have to understand. All right. Next, we talk about abnormal movements. Talking about the abnormal movements, the first most abnormal movement is tremor. Two most important causes of tremor. One is Parkinson tremor. Whenever there is Parkinson tremor, it is usually unilateral. Nowadays, the examiner is asking about bilateral tremor in Parkinson patient. It is basically drug-induced Parkinsonism. Whenever there is drug-induced Parkinsonism, it is bilateral tremor, and the investigation of choice is DAT scan, DAT scan. All right. Additional features of Parkinsonism can also have bradykinesia, rigidity, and tremor. All right. This is one thing you will have to remember. And remember, MRI is the investigation of choice. If MRI is not available as the initial investigation, you will have to go and select a DAT scan. All right. Next, we talk about chorea or chorea. Chorea is usually seen in Huntington. Remember, Huntington's, there is a thing called anticipation. Whenever there is anticipation seen in Huntington's disease, it is nothing but the family members are affected. In successive family members are affected in much younger age. That is what you'll have to remember in chorea. Sydenham's chorea, for me, it is the infection or previous history of sore throat with streptococcal, and now after 10 years the patient presents with the chorea, that is Sydenham's chorea. Next, hemibalismus is basically large amplitude movements, which is basically because of the damage to subthalamic nucleus that is causing hemibalismus. Athetosis is one most important abnormal movements we will have to remember, because athetosis can be seen in multiple sclerosis. Pseudoathetosis can also be seen, that is basically because of the severe proprioception loss. All right. Next, we talked about cervical dystonia. Dystonia is basically a sustained abnormal posture. I want you to understand that whenever there is dystonia, botulinum toxin can be used for these patients, please. Very important. I think the examiner can ask you about these questions in PLAB exam. There is this syndrome called tardive syndrome. Whenever there is tardive dyskinesia, we will discuss next as well. Tardive dyskinesia, whenever it is present, it is basically because an extrapyramidal symptom, or basically because of the use of antipsychotics and sometimes use of antiemetics as well. All right. Whenever there is tardive dyskinesia, the examiner can tell you that the patient has got abnormal movements of the lips or the trunk, or patient can be having chewing movements or grimacing movements. This is the classic example of tardive dyskinesia, usually seen in patients who have got antipsychotic use. I also want you to understand that treatment of tardive dyskinesia is a bit difficult. The first most important thing is withdrawal of the antipsychotics that can cause tardive dyskinesia. What is the drug of choice for tardive dyskinesia? It is tetrabenazine that can be used for tardive dyskinesia. All right. The examiner can also ask you which of the following medications will be having less effect to cause tardive dyskinesia. It is the quetiapine, it is the olanzapine, and it is the clozapine. These are the most important medications or atypical antipsychotics that are less likely to cause tardive dyskinesia. Remember again, it is quetiapine, it is olanzapine, and it is clozapine. All right. Thank you very much. I'll discuss about the stroke in the next session.